Dr. Laramore, who is our Peter Wootton Professor, Chair of Radiology Oncology at the U, and Director of the University Cancer Center here, and the Medical Director at the Seattle Cancer Care Alliance for Procure Radiotherapy Center. Consultant at Seattle Children's, Veterans Puget Sound Care, Harborview, and the Gamma Knife Facility at Northwest. And I'm really excited to hear about the neutron radiotherapy. And also, looks like a big diver down in Hawaii last year. Turkey, traveling in Turkey, this is beautiful. Look at this blue sky, you guys. And you can see that he's a physicist, and then earned his MD in University of Miami, and did his residency here. And I think that do you guys kind of get this theme maybe that those of us who kind of trained here always come back? We come home, we stay, and we come home. Even though I was a California girl, I came up here and I haven't gone back. It's Dr. Laramore.
Thank you. I'm going to shift gears a bit. I'm going to talk about an alternative form for local regional treatment. That's radiotherapy. First, conflict of interest. What that means is anybody giving me a large sum of money to slant my talk in favor of their product or service? Unfortunately, the answer is no. What I'm going to do is first give a little bit of a historical perspective. I'm not going to really go into this very much because we only have a half an hour. Then I'm going to talk about radiotherapy options as they exist today. Brachytherapy, or more commonly known as seed implants, external beam radiation with photons or X-rays, and something new on the horizon, a proton beam that some of you may have read about as something that may or may not bankrupt the country even if it works as well as intended. First question, does radiation work? There's a Scandinavian randomized trial that was reported in the Lancet in 2009. It showed that external beam radiotherapy improved 10-year survival. This is the study. It was for patients who had locally advanced prostate cancer, 77% T3. These are the ones you can feel and maybe outside the prostate. And 23% were T1 and T2 high-grade lesions, a total of 875 patients. These are the rabbits and some of the birds that Dr. Lin told you about. Now, prostate cancer is something that's driven by hormones, androgen. So one way of kind of slowing down the rate at which prostate cancer grows is to shut off the androgen drive. There is a pituitary hypothalamic axis that releases a hormone that tells the testes to produce androgen. So you can shut it off here, and that's what the LHRH agonist means. Now, the testes aren't the only thing that produces an androgen. There are other organs in the body that does as well. And so you can also block this at the cell receptor. So this is flipping the coin. Half the men just had the androgen suppressed. The other half had the androgen suppressed plus external beam radiotherapy. If you look at what's called PSA recurrence, that means the PSA started going up again, and so you had an evidence of failure. You found when we treated a patient with androgen ablation alone, at the 10-year point, close to 80% had failed. If you added external beam radiotherapy and looked at PSA as a surrogate for tumor failure, the failure rate was about 25%. But what people are interested in is survival. And if you look in the literature, there are two types of survival people will tell you about. One of them was called cause-specific survival. That is, did the cancer kill the patient? The other is just called overall survival, and that means the patient died of something. So if a patient was treated, and then 6 months later stepped out into the street and was hit by a bus, on the cancer-specific survival, he's considered a censor observation, meaning he was considered in control at the time he died and just wasn't followed thereafter. In the overall survival, he was considered a death. And so that's why the curves are different. But on both of these measures, adding external beam radiation to hormones improved the overall outcome. The linear accelerator is what a radiation oncologist uses today to produce the X-rays that we use to treat the cancer patient. Now, I'm going to show you some equipment that's substantially bigger, but I want you just to get a sense of perspective. This table here is where a patient would lay, so that gives you some idea. These accelerators are pretty compact these days. They're an outgrowth of the radar technology that was developed at the MIT Lincoln Labs during World War II for the waveguide technology and the klystron oscillators, and things are really very compact. These accelerators accelerate electrons to several million electron volts, impact them on a tungsten target, and produce the X-rays that we use in cancer treatment. If I look at how things were in 1991, about the time PSA came online, we did what we would call conventional external beam radiotherapy. We had fairly primitive imaging compared to what we do today. We would take a photograph, X-ray, outline where the prostate was relative to the bony landmarks, inject dye in the rectum and try to design the radiation field to try to block out as much of the rectum as possible. And looking at that, just basically make the field somewhat conform to the prostate. Now, why have we tried to do better? If I step back, maybe I'll ask a different question. Why does radiotherapy fail to control tumors? In particular, why did we want to go beyond what we could have done in the early 1990s? Succinctly, radiation fails to control tumors because of our inability to deliver a sufficiently high dose of radiation to the tumor without damaging adjacent normal tissues. Radiation actually works in fairly subtle ways with tissue, but you can think about it phenomenologically in terms of what we call dose-response curves. If I'm giving a certain amount of radiation along this axis, I look at the percent tumor control along this axis. Not much happens for very low doses of radiation. Then tumor control starts to increase, and it should asymptotically approach 100%. Now, near the tumor is normal tissue that limits the amount of radiation I can give. For prostate, it's the bladder and the rectum. And so I have a similar curve like this for normal tissue damage, which I'm plotting over here. Now, if these curves are widely separated, meaning that the normal tissue is more resistant than the tumor, this is great. This is radiosensitive. It means I can give a sufficient dose of radiation to control like 90 or 95% of the tumor. My complication rate's only about 5% or so. But what happens in other situations where these curves lie very, very close together? Then if I try to give enough radiation to control like 90 or 95% of the tumor, I have an exceedingly high complication rate. And that's not what we do. What we do is decide what is an acceptable complication rate. And then we give that amount of radiation, and we take whatever tumor control we give. So the whole idea is to try to figure some way of sparing this normal tissue. So I walk up the tumor control curve, but I don't walk up the normal tissue damage curve. Probably one of the best examples of this for prostate cancer comes out of Memorial Sloan Kettering. They took patients and they gave, in a randomized sense, varying amounts of radiation. This is gray, so 65 gray on up to 81 gray. Now, prostate cancer, in many cases, is a slowly growing tumor. So I give radiation. The cells are killed, but they don't know it yet. They continue to live, but they can't reproduce. So if I give the radiation and then immediately I biopsy the tumor, I'm going to see something under the microscope that looks like living cells. But I can't tell if they're actually going to go on and continue to grow. So the people at Memorial, they built in a biopsy of the prostate in all the men that were treated at times greater than 2.5 years to allow for these apparently normal tissues to go ahead and die. What they found was the control rate increased dramatically. The failure rate was 67% for the lowest dose, 4% for the highest dose. The problem was complication, in this case called grade 2 rectal bleeding. For the two lowest dose arms, here and here, it was 6%. The higher dose, 17%. So that's my trade-off. That's what happened in terms of the older way we would give radiation. Snyder and co-workers took a look at all the data in the literature they could find as of about 2007. And this is an expanded form of that dose-response curve, starting out at about 50 gray. And you can see it going up. And this is where we're working today, pretty much around 80 gray. So we should be controlling about 85% of the tumors, the low-risk tumors. To go higher, going up to 90 or plus gray, it's going to take a lot more work. And that's what I'm going to tell you about later on. So what do things look like today, 2011? Besides the conventional external beam radiotherapy, we have very conformal external beam radiotherapy. That means I target the dose to the prostate, not to the rectum, not to the bladder. I can do this with 3D conformal techniques, something called intensity modulated radiotherapy, or proton beam. I can use a cyber knife, or stereotactic body radiotherapy, high dose rate and low dose rate brachytherapy, brachytherapy with external beam, and we can use any of the above with androgen deprivation. So there's a lot of different ways we can treat prostate cancer, and the idea is try to individualize it to the particular situation. Brachytherapy is radiation from the inside. We do this in two different ways. One of them is called a low-dose seed implant. The other is a high-dose temporary implant. This is the so-called prostate seed implant that you probably read about and people are more familiar with. This is a very good treatment option for the appropriate patient. It's inexpensive, it's convenient, it's done all in one setting. The cons are it requires very much a lot of technical expertise, causes a small gland size, and good pre-treatment urinary function. Otherwise, you can have a lot of urinary problems afterward. The seeds are, this is the relative size to a finger, quite small. They're placed into the prostate from below, and this is the radiation doses that conform very nicely to the distribution of the seeds. This is how it's done, basically with a template. Needles coming in. There's a transrectal ultrasound that's used to guide the needles. So it can all be done in real time, and you can then plan the delivery of the seeds as you go along. If one seed's a little bit out of where you normally wanted it, you can compensate with the next one by doing the calculation of the radiation dose as you go along. The thing that I'm most excited about is proton radiotherapy, which gives us the very precise physical dose targeting. First, what is a proton? A proton is the nucleus of a hydrogen atom. Hydrogen is the most common element in the universe. On Earth, we see hydrogen mainly in its oxidized form, H2O or water. Coming in tonight, we all walk through some oxidized hydrogen. What we do is take these protons, the hydrogen nuclei, ionize them, and accelerate them. Why do we want to do this? It's because protons, being a charged particle, have very different properties in how they interact with matter or tissue. Imagine that I want to treat a tumor that's about 20 centimeters deep. If I have an X-ray beam coming in from the side, it builds up, falls off, and then falls off beyond the tumor. So to give like 50 centigrade of radiation here, I have to give 100 here, and I have a lot of wasted radiation treating normal tissue on the way out. A proton beam, on the other hand, goes in, doesn't deposit much energy, it gets very near the end of its path. Then it deposits a lot of energy in the so-called Bragg peak. What I can do is sweep this Bragg peak across the tumor, giving this composite curve. So what I've done, I have a very sharp fall off, so I don't have any radiation of normal tissue beyond the beam, and I have much less radiation of normal tissue on the way in. The depth at which the proton beam penetrates depends on its energy. In the early days of proton radiotherapy, the beams were fairly low energy, and they didn't penetrate very well, and a lot of superficial tumors were treated, eye tumors and head and neck tumors. For prostate, you need to give energies that are in the range of over 200 MeV, and this is about 2/3 the speed of light. We didn't get into the proton beam business strictly for prostate cancer, although I hope to show you that it's a very good form of treatment. We got into it because of other indications. One indication is called a uveal melanoma, or a tumor of the retina of the eye. This is one of the first things that were treated. This is one of the older treatment planning calculations. This is an eye. This is the lens of the eye. This is the tumor. And this is how precisely we could focus the proton beam radiotherapy, treating just an octant of the eye. Results were extremely good. Massachusetts General Hospital, Nice, the Paul Scherrer Institute in Switzerland, overall about 4,000 patients treated. Local control rates as far as tumor in the eye were running about 90 to 95%. And importantly, the eye retention rate ran about 95%. The surgical alternative is an enucleation, or taking the eye out. Other classes of tumors that we were very interested in were these that wrap around the spinal cord. Tumors that aren't operable. But there's no way, you have to basically be able to treat in a circumferential manner the radiation dose, and protons allow you to do this. The Lawrence Berkeley Laboratory in the Massachusetts General Hospital, treating chordomas and chondrosarcomas in this type of configuration, controlled 50 to 60% of them. And again, there's no other alternative. But the real reason that we got into this in Seattle was the pediatric population. There's a type of tumor in children called a medulloblastoma. It develops in the back part of the brain. It spreads down along the spinal axis. And to treat it, along with chemotherapy, you have to radiate every place that it's going to spread. If you do this, radiation coming in the back with X-rays, you have that exit dose. That exit dose goes through the intestines. It makes the child nauseated. If it's a girl, you're treating through the ovaries, so you can have loss of fertility. Treating through the heart, you have greater risk of cardiac problems later on. With protons, though, you can exquisitely stop the beam, so essentially it does not spill past the spinal column at all. Treating the part of the tumor that's in the brain, both protons and photons, or IMRT, do a nice job of giving a high dose to the tumor. On the other hand, the IMRT gets a lot of spill dose through the optic nerves, the pituitary, the inner ear. And if you look at complications of treatment, and look at all types of complications, cardiac, endocrine, hearing loss, risk of second malignancies, and neurocognitive changes, at 20 years, the overall risk with standard radiotherapy is about 48% compared to 7% with protons. Now, a lot of people say, well, yeah, those are very nice pictures, but can you really stop the beam that way? This is a set of scans from MD Anderson where actually they took a look at, this was the pre-treatment scan, wanting to treat along the spine. This is the treatment plan, stopping the beam partway through the vertebral body. And this is an MRI scan several months after treatment. What I call your attention to are these changes in the bone marrow. This is a radiation-induced change. And you can see the beam really did stop halfway through, just like it was planned. Now, why prostate cancer? One thing we can do is increase the the tumor control probability, or TCP, by giving more dose to the cancer. We also can decrease the normal tissue complication probability by having less dose to the rectum, less dose to the bladder, and less overall dose to the patient. Now, these are some isodose distributions. Brighter the colors, higher the dose. X-rays on the left, protons on the right. And you can see that with even a single beam coming in, you have a lot of spillage. This is not the way you would normally treat somebody. You would use beams coming in from multiple different directions. With protons, you actually can do a pretty good job of just using one beam if you want to, but you bring in a beam from 3 different ways, and it really conforms nicely. Essentially no exit through the rectum. You also have a lower dose to the bladder. If you compare a proton plan versus an IMRT plan, which is this kind of the standard used in the community today, again, look at all the extra tissue that's being radiated, rectum and then a lot of the pelvic tissues. These irradiated tissues are at higher risk for developing a second cancer. Truth time. There have not been any randomized trials that directly compare proton radiotherapy with standard radiotherapy for prostate cancer. There was one study done that looked at giving initial amount of radiation to the prostate and pelvic area with X-rays, and then doing a proton boost. And patients were randomized to receive two different proton dose levels. A lower dose of 19.8 gray or a higher dose of 28.8 gray. This is after getting 50 gray conformal X-ray treatments. If I look at low-risk patients, the high-dose area, and this is this more or less conventional dose, higher doses do better, just as you would expect. But what was interesting is there was really no difference in significant toxicity with the protons when you went from the lower dose to the higher dose, unlike that escalation study I showed you from Memorial Sloan Kettering with X-rays. There have not been any direct studies, but there have been some comparative studies where people have tried to look at what they think are equivalent patients. A proton group from that cooperative trial I showed you about, and the Memorial Sloan Kettering group, where the 10-year local control rate for low risk, 93% versus 81%. Now there's some asterisks there to remind you that when you're looking at the literature, if somebody who have prostate cancer, have a friend of his, you're going to look at the literature, you're going to see control rates. There are different ways you can define control. When Dr. Lin takes out a prostate, the PSA falls immediately. When you radiate, it falls over time. And if you fail, then it's going to start to come back up again. So how do you define a point of failure? Initially, there was what was called an astro definition. So PSA went down, it came up, and if you had 3 consecutive rises, you said it's a failure, and you backdated it. You went back to the point where it first started to rise, and took a point halfway between the nadir, where it's low point, and then where it first rose. The other was called a phoenix definition, where the thing went down, and it had to get above a certain level, which was basically 2 nanograms above nadir before you called it a failure, and you didn't backdate. So these numbers are different, and they can be different, and so you need to be very careful because typically the astro definition is going to give poorer results for the same time point than the phoenix definition. So that's something just to be aware of. Proton beam versus brachytherapy. Again, no randomized trial, but a comparative study out of the Massachusetts General Hospital would say, in terms of overall control, they're about the same. I think a real difference is the risk of second cancers. In 2008, there was a comparison made between a proton patient treated at the Massachusetts General Hospital and a control group from the SEER database. This is a surveillance database. And it found that the proton-treated group decreased the risk of patients developing a second cancer by about 50% compared to what they think were a comparable group of patients treated with X-rays. If I look at prostate cancer specifically, baseline risk over a 5-year period of developing a second cancer, about 4% baseline, conventional radiotherapy, 10%, IMRT, spreading the dose out throughout the tissues, 11 to 15%, protons, 6%. If you wanted to go for proton radiotherapy today, closest place would be Loma Linda, California. Next closest place would be Oklahoma City. The Seattle Cancer Care Alliance is partnered with Procure to build a proton center, which will be on the Northwest Hospital campus and will open in early 2013. It's a very large facility. The cyclotron accelerates the protons. There's a beam line which transports them down into 1 or 4 different treatment rooms. The size of the facility is about 56,000 square feet. If you look at that, that's 1.25 football fields. The footprint is about 2/3 the size of a football field. The cyclotron itself, this is what produces the high-energy protons up to 2/3 the speed of light, this weighs 250 tons. The one we have is being built in Belgium. It's being transported by ship and will be installed in the building next month, actually. This is the beam transport line. builds on nuclear physics technology with focusing magnets and bending magnets. And then the beam is spun out into one of the 4 different treatment rooms. The gantry, this is the thing but like the X-rays that were spun around the patient. This is now over a 6-foot man. You get some idea of the size of it. The beam comes in here and is bent around with magnets and then exits here in a nozzle. This weighs 175 tons, yet when you spin it around 360 degrees, the wobble is less than a millimeter. And you can correct the beam with software to less than that. And that's how you can get that precise number. That earlier show we were treating part of an eye. This is what it looks like on the inside. So the patient sees something that's very similar to a standard X-ray. Groundbreaking was in March of last year. This is the Chief Executive Officer of Seattle Cancer Care Alliance, Jim McDermott, who has been a strong supporter, a couple gentlemen from ProCure. After about a year's digging, this is what the facility looked like at the end of last year. Anticipate the first patient will be treated in March of 2013. As I say, I think it's a very good form of treatment for prostate cancer, and we certainly will treat prostate cancer there, although the main emphasis we have is for the pediatric population and some of the other types of tumors that are maybe more aggressive than most prostate cancer. But in terms of a slide, I'm going to close with a slide that's not too much different than Dr. Lin was saying. In terms of cure, surgery, brachytherapy, and high-dose external beam radiotherapy seem to yield similar control rates. Side effects are different for each modality. You might see a higher incidence of urinary complications with surgery. You might see a higher incidence of rectal complications with radiotherapy. The cost and convenience can vary widely. It can be bewildering for the patients. You may find that eligibility for each option makes the decision process easier. If someone, for example, has a very large prostate and has urinary problems, but not really a candidate for brachytherapy, you can rule that one out right away. And finally, I would certainly echo what Dr. Lin said. I think for many patients, a no treatment observation approach is equally valid to treatment. The key is to select out which are these turtles as opposed to the rabbits and the birds. Thank you.